Hi, good afternoon, everyone. I'm Eleni Angelas from Community Health and Wellness at Suburban Hospital. Today, we are joined by Dr. Kendall Moseley, who will be speaking to us today about osteoporosis, how to bone up our bones. Before we begin, I just want to go over a few housekeeping items. The first is that today's presentation is being recorded, and we'll make that available in the coming days. Secondly, please, I know some of you probably have lots of questions. Please use the Q&A box at the bottom of the screen to ask your questions, and Dr. Moseley will be able to answer all of them, hopefully all of them. And last but not least, for the evaluation, I will send an email after this presentation, after the webinar is over, and a link for the evaluation. Please take the time to fill out that evaluation. We do take your feedback very seriously, and also suggestions for the future. So without further ado, here's Dr. Kendall Moseley. Thank you.
Great. Eleni, thank you so much for that introduction, and hello to all of you virtually. I think we're all finally getting used to this very odd format in which we do talks now, but nonetheless, I hope you'll learn a thing or two. I was asking Eleni who my audience was today because I think it's important to kind of know to whom you're speaking, and I will hopefully be able to impart upon you some little tidbits as well as some basic knowledge about osteoporosis, as it's near and dear to my heart. Just a little bit of background on myself as I try to share my screen with you all, is that I am the director of the Metabolic Bone Center. So I am kind of responsible for a lot of patients at Johns Hopkins Bayview and Johns Hopkins in general with metabolic bone disease, most commonly osteoporosis. It's my clinical passion. It's my research area, and certainly something I enjoy speaking about on a regular basis with a lot of joy. So I do think it's always helpful to start this session with a definition of osteoporosis. There's a lot of words on this slide, and I really hope to distill it down to kind of its core issues. But all of the words basically say a systemic skeletal disorder characterized by low bone mass and microarchitectural deterioration of bone tissue with a consequent increase in bone fragility and susceptibility to fracture. So what can we pull out of that definition? So number one, a systemic skeletal disorder. So even though many of you may have already had something called a DEXA scan or a bone density test, where all we're doing is looking at the spine and the hip, and sometimes we get a forearm, really that imaging test is supposed to be a surrogate or kind of a representation of the rest of your body because it's a systemic disorder. We're talking about low bone mass and microarchitectural deterioration. So again, even though sometimes we just look at this fancy x-ray, the DEXA scan, we also want to think about what lies beneath the bone. So that microarchitecture, that bone quality. And then probably the most important thing about this definition is the very end, where we talk about the consequent increase in bone fragility and susceptibility to fracture, because that's what we care about, is the fragility of the bone and then the fracture, which inevitably can lead to some poor health outcomes. So again, what is osteoporosis? Distilling it down to its most basic concepts, we've got bone deficiency, we have bone thinning, we have bone loss and bone weakening. So that's what we don't want to happen as we age or with other medical conditions. We don't want our bones to become weak. And, why do we care about it? You see the pictorial here, although, when I think about my clinic, this is not my typical patient. So, I've got patients of all walks of life. I've got older patients, unfortunately have some younger patients. I have, all races, all genders, all sorts of health backgrounds. So this is just but one picture of what osteoporosis looks like. But again, why do we care? Well, this is a classic story. So the little old lady who falls and she breaks her hip, and, this older woman may be living at home. She may have a spouse. She may have animals that she enjoys taking care of and a garden. She may have all sorts of things that she enjoys doing in her life, grandchildren, etc. And unfortunately, that fall can lead to a broken bone, hospitalization, prolonged hospitalization, discharge to a rehab facility. Sometimes there's complications there, sometimes readmission to the hospital. And then unfortunately, we realize that these patients can lose their independence in life. And unfortunately, they can even lose their life in some extreme circumstances where fracture can ultimately lead to death. And so when we look at the dismal statistics, you can see the numbers here, and these are definitely things that we pitch when we're looking for funding for projects. But 10 million individuals in the United States are thought to have osteoporosis, about 8 million of those women and 2 million men. I would argue this is actually a much higher number than what we're fully capturing. I think we don't screen like we should for osteoporosis. I think we don't recognize that fractures in older individuals may in fact be osteoporosis. So I think this is an underestimate. And I think men are particularly underestimated in these numbers, namely because we still tend to think about this disease, it's a woman's disease, when in reality, men can very easily have thinning of the bones and fracture too. You see here 50% of women and 25% of men will have a fracture in her or his lifetime. 25% will die in the first year following a hip fracture. So that rivals really any numbers associated with stroke or heart attack. And you can look at the cost of osteoporosis here. I mean, $25 billion. We talk all the time about the costs of healthcare and medications and hospital stays, and we really can't underestimate osteoporosis being a leading contributor to some of those increased healthcare costs. So today we have a few goals. The first thing we want to talk about is kind of what causes osteoporosis. How do we get to the stage where we're worried about bones and bone fracture? We want to talk about risk factors for bone loss and how we kind of screen for those and think about those. We want to talk about things that patients that you all can do to improve your bone health. I think it's always helpful in the clinic to not only, dole out prescriptions, but also to say, gosh, what can I put on your list of things to do at home to empower you to take control of your bone health? And then what are some specific treatments? If and when I do need to pull out that prescription pad, what are some things that I generally will prescribe or consider prescribing? Again, not only to make the numbers look prettier, but really to prevent fracture, which is our goal at the end of the day. So I promise you we're not going to get too much into the biology of bone, but I do find it's really, really helpful to think about bone as kind of a dynamic organ, right? We're not walking around like rocks all day long. Bone is always building up. It's always breaking down. It remodels. That's a term that we use a lot in the bone community. And the reason why it's always kind of recycling itself is to keep it flexible, to keep it, so we can heal. Every time you twist or bend, believe it or not, and maybe scarily enough, you're introducing these little microfractures into your bone. And those little microfractures have to heal themselves. Otherwise, they turn into microfractures and then they get bigger and then big fractures that we don't want to see happen. So remember this dynamic process, the building up and the breaking down. And ideally, we want that buildup and those breakdowns to be relatively equal, right? We want to kind of lose bone, but we want to put it right back again. And it's really only when you see kind of an imbalance and that buildup and breakdown cycle that we can see things like bone loss. These are the cells responsible for that buildup and that breakdown. And these are the cells that really we're targeting with our therapies. This is where all the research is to try to optimize this remodeling process. We have the osteoclast, which is kind of like the Pac-Man cell that comes along and chews up old bone, makes these little pits of bone in the skeleton, or pits of resorption in the skeleton. And then the osteoblast, B as in build, comes in and fills in all those little pits created by Pac-Man with new mineral to hopefully renew that bone. And again, it's when the osteoclasts are a little bit busier than the osteoblasts that we start to see bone loss. The other thing that we always want to do in the clinic is not to think about bone in kind of this singular moment. We got the DEXA scan, we see osteoporosis, but gosh, why are the bones the way that they are? We have to think about the entire life cycle, believe it or not, because as you can imagine, there's different things that happen along one's life that may impact bone. Men and women gain bone until about the age of 30. So kind of the most bone that you're ever going to have in your lifetime, you acquire or reach your peak by about the age of 30. You can see with that green arrow, you're building up a little bit more than you're breaking down. There's a steady state that all of us hit after the age of 30. And for women, it's kind of between 30 and the time of menopause. For men, it's between the age of 30 and about 70. Where really there's a balance of buildup and breakdown that should occur where you're kind of not, gaining too much or losing too much. You're about the same. Women go through a menopause generally around the age of 50, sometimes earlier, sometimes later, where there's more breakdown than there is buildup. So there can be net bone loss. And then men a little bit later with testosterone decreases and muscle mass decreases around the age of 70, we see a little bit more bone loss. And so in clinic, we always draw this picture. We always start go from beginning to end to say, gosh, where did things start to go wrong? Genetically, were you destined to reach that peak bone density by the age of 30? Maybe there was a childhood illness. Maybe between 30 and 50, there was a medical diagnosis that popped up where there was immobility or medications that might impact bone. What's happened along that curve to kind of create your current picture of bone density, which ultimately we gain with our DEXA scan. So this is generally what patients have when they come to see us. If not, we order one. But this gives us an overall impression of what the bones look like. And as I indicated, we generally look at the spine and the hip and sometimes the forearm. And they're basically simplified x-rays measuring how much bone you have in that skeleton to give us a sense of your risk for fracture and really to define you based on this classification here as to whether or not you have normal bone density, low bone density or osteopenia, osteoporosis, or severe osteoporosis. And you can see here, osteoporosis is a T-score of anything less than or equal to a negative 2.5. And what is a T-score? It's basically comparing you, whatever age you may be, to a 30-year-old. And why 30 years old? Well, gosh, I just showed you the picture, right? So you reach your peak bone density by the age of 30. So you compare to your ideal, where do you fall on that spectrum? And these numbers themselves are actually standard deviation. So for our mathematicians out there, statisticians, a standard deviation off of the norm is how we gauge, again, normal osteopenia or osteoporosis. I will say right now, if you take nothing else away from this talk, I want you to hear this. I don't care what your T-score is. If you have had an osteoporotic fracture, and what is that? That is a fracture generally of the wrist, the spine, the hip, the pelvis from standing height or less, that is osteoporosis. And it doesn't matter what the T-score is. If you fall on the ice and you break your wrist, if you slip in the kitchen, land on your bum and, fracture your pelvis, I don't care if your T-score is completely normal. That is osteoporosis and merits definitely some additional workup, if not treatment. So who should be screened? So, according to Medicare, definitely by the age of 65, most individuals should have a DEXA scan if you're a woman. If you're born male, by 70 or above, you should have a DEXA scan. But more commonly, and certainly in my clinics and in the primary care offices, we get these DEXA scans sooner. So for example, if there's an x-ray that shows reduced bone density or osteopenia, sometimes is called, that should push one towards getting a DEXA scan, or if there's a presence of a risk factor for low bone density. And I'm going to go through a laundry list with you. Essentially, most people have some sort of a risk factor for osteoporosis, generally by about the age of 50 if you're female, or even a little bit older as a male. So menopause is a risk factor for bone loss. So I have yet to meet a 65-year-old woman who's not gone through some sort of a menopause. Again, men older than 70, family history and race. So we know that Caucasians and Asians generally, and this is actually a subject of a lot of research right now, have lower bone mineral density than, say, Black or Latino peers. Low body weight, so a BMI less than about 18, medications, things like steroids or aromatase inhibitors or androgen deprivation therapy, alcohol abuse and tobacco abuse, personal history of fracture. So again, if I'm talking to someone and I hear, I broke a wrist or I broke a vertebral body, I want to know what that DEXA scan looks like. Estrogen deficiency, so early menopause, testosterone deficiency in men, vitamin and mineral deficiency, for any host of reasons, malnutrition, gastric bypass, celiac disease, et cetera, will all kind of result in these nutritional challenges. Immobility. So sometimes, patients have various reasons for why they don't get around like they used to, and we have to take all of that into account. And then, as promised, the laundry list of other medical conditions that can really threaten the skeleton. And as much as I love the bone, unfortunately, the bones are at the bottom of the totem pole. So if the system takes a hit, if there's a chronic disease, if there's a medication, if there's any sort of nutritional challenge, one of the first organs that starts to, suffer because of that condition is going to be the bones. So you can see there's a number of rheumatologic conditions, not just because of the steroids used to treat these diseases, but also just the inflammation itself can lead to bone loss. A number of endocrine disorders, any sort of gastrointestinal disorders, again, not only for the inflammation, but because there can be malabsorption of nutrients. A number of different cancers. There's several medications on this list that include, your glucocorticoids, like we talked about, seizure medications. There's some data out there looking at SSRIs or antidepressants and proton pump inhibitors for gastroesophageal reflux disease. That data is a little bit less strong. So again, if you need your antidepressant, as many of us do these days post-pandemic, please, we're not taking people off of those. And certainly with reflux disease, if you're suffering with reflux, we try not to stop those medications too. And then there's a number of other chronic medical conditions, which you can see down here, ranging from liver to kidney to multiple sclerosis, all sorts of things that really, if you have any of these, you should get your DEXA scan. And then what? So I tell patients, in fact, I just told patients yesterday, my new patients, I said, listen, it's rare that I ever pull out my prescription pad when I first meet someone. Even if that DEXA is showing me osteoporosis, even if there's a fracture, I want to make sure I'm not missing anything. I map out the curve, but gosh, am I missing a vitamin or mineral deficiency? Am I missing a hormone problem? So there's a series of labs that I generally order to make sure there's nothing else that I need to correct before we think about treatment, including a complete panel and a phosphorus, their calcium issues or kidney problems or liver problems. Thyroid testing, everybody gets a vitamin D if they don't come with one, and many people get that with their primary care doctors now. Parathyroid hormone, which is made in the neck, it's kind of a neighbor of the thyroid gland, but it kind of regulates your calcium and your vitamin D levels. I torture everybody with a urine collection for 24 hours to look for calcium content to make sure you're getting enough calcium and not putting too much out. And then I screen generally for multiple myeloma, which is a rare blood cancer, but can sometimes cause slow and steady bone loss in some patients, and we certainly don't want to miss that. There's some additional labs that sometimes I get if we get kind of a physical exam that's a little bit suspicious, or if there's a clinical history of things like rashes that might prompt me to get additional laboratory testing, and a bunch of other things that we'll order, again, just depending on the patient. What about treatment? So, as promised, there's things you can do and things that I can do, ideally not only to maintain your bone density, maybe get you a little bit of bone back, but importantly to prevent fracture. And you'll see really the major things on this list, the diet and the lifestyle, that's on you. That's on the patient. I'd love to follow you home and remind you to exercise or to eat well, but these are all things that we kind of need to take ownership of as best we can, and within the limitations that we all have with respect to what we can eat, what we can tolerate, the exercise that maybe we can't do because of chronic pain or other immobility issues, but we do our best. And that's always what I try to impress upon people. Pharmacologic intervention. And then obviously, if we find anything in all those labs that I torture patients with, we try to correct those too. So if there's lab abnormalities, we don't ignore them. We try to treat those before we get underway with some of these other things. So a hot topic is always calcium with patients. What about calcium? Well, guess what? Calcium is really important for bones. It's a building block of bone. It's one of the critical elements of that collagen matrix that comprises your bone. And we do know that calcium deficiency results in thin and soft bones. So calcium goal for individuals greater than the age of 50 or those at risk for osteoporosis is about 1,000 to 1,200 milligrams per day. And this is, IOM guidelines. So this is not me going out on a limb. And ideally, we want to get our calcium through the diet, ideally. So things, that have calcium in them, milk, yogurt, cheese, non-dairy products. So gosh, almond milk, soy milk, cashew milk, oat milk, all of those things now, believe it or not, have a ton of calcium in them. And a lot of patients choose those items over, say, a supplement. A lot of patients have dietary issues. Maybe they just can't eat enough food to get the necessary dietary calcium, or maybe there's dietary restrictions or lactose intolerant or whatever the case may be. So if necessary, supplements are a possibility for patients. There's a whole variety of calcium supplements out there when you go to the drugstore. And generally, we recommend in our clinic calcium citrate as opposed to calcium carbonate. Calcium citrate is better absorbed. It causes less GI discomfort. Constipation is a major complaint with some of these supplements. It's better absorbed. It's better tolerated. It just tends to go down a little bit easier. So again, calcium citrate. The key is you have to read your label. It's very common. You need multiple pills of calcium citrate to equal what one pill of calcium carbonate is. So apologies in advance. And when you take your calcium, either through the diet or through supplement or through combination, it doesn't matter. Just get that 1,200 milligrams. Try to sprinkle it throughout your day. So the gut can really only absorb about 600 milligrams at once. So don't take your supplements plus your glass of soy milk plus your handful of, almonds all at the same time, because about half of that's going to be wasted out the other end. Vitamin D, and actually I'm going to go back because I don't have a separate slide on this, but I do want to comment something that always comes up during these webinars and in community talks is what about heart health? So believe it or not, the American Heart Association and the boneheads, of which I'm a bonehead, have really agreed upon this goal of 1,000 to 1,200 milligrams a day in patients at risk for osteoporosis. If you're normal, nobody is saying you need to go out and pop a bunch of calcium pills. But if you're at risk for bone loss or have fractured or you're on osteoporosis treatment, even the cardiologists agree that this is a reasonable goal. Their preference is dietary calcium over supplement, based on some data, at least in high-risk cardiac patients, that supplements can cause vascular calcification. There's other publications that don't show that. But again, the compromise is right here. And again, if you are at higher risk for cardiovascular disease or have had myocardial events in the past, dietary would be a preferred form. But again, this is still the goal. Vitamin D, it's interesting. So the IOM, the Institute of Medicine, recommends 600 to 800 units per day, but I think we all know that this is relatively insufficient for most people to maintain blood levels somewhere 30 and above is what we like in our clinic. So 30 nanograms per milliliter and above. You can get vitamin D through food sources, so fatty fish and fortified foods, or even from sunlight. The challenge is that on days like today, where it's freezing cold outside and we're fairly far away from the sun and we're wearing sweaters and scarves and hats and covering ourselves up, it's really hard to get sunlight as a source of vitamin D. So many patients will, in fact, take a vitamin D supplement. Many individuals are on somewhere between 1,000 to 2,000 units per day. It depends on your blood levels. Again, this is the individualized approach to bone health. But vitamin D is important for bone. And there was a paper that came out about a month ago that looked at fracture risk and vitamin D. And of course, all the patients wanted to talk about it in clinic. And that paper, basically, the conclusion was that vitamin D does not prevent fractures. Well, the shortcomings of that paper were that the patients in question in this study were really not those at high risk for fracture. They had just a small sub-study of individuals with osteoporosis. And importantly, all of the participants in that study, or the average value of vitamin D in participants in that study, was normal. So basically, the conclusion of the study is that if you have normal vitamin D levels, taking extra vitamin D doesn't prevent fracture. And I think that's obvious, right? If you have normal vitamin D levels, why would you ever need to supplement it? So, in the bone community, our party line is, if you're in my clinic, chances are that paper doesn't apply to you. But again, we try to take an individualized approach and work with patients on vitamin D supplements in the interest of their bone. Protein, please don't forget about your protein. Collagen, which comprises bone, is collagen, is protein. So if you are protein deficient, you're going to have some bone deficiencies and softening of your bone. So you'll see your goals here, and it doesn't have to be meat. It can be eggs and tofu and beans and tempeh, whatever food source you choose, that's fine. Just go for your goals. And then exercise. It has been really challenging, I think, for a lot of us recently, exercising when the gyms were all closed down. They're open back up again, but many of us feel uncomfortable going back into them. Nobody expects you to go to a gym. You can actually fulfill your exercise goals of 3 to 4 days per week, about 30 minutes, just by walking. Take a walk outside, not, with your dog where he or she stops every 2 seconds to urinate, but, go for a nice brisk walk outside. That counts as resistance training. If you want to do free weights at home or gentle aerobics at home, really the only thing that doesn't count is swimming. And it's good for the mind and body, and fall prevention, right? So even if you're not out there pumping iron, just a little bit of exercise can help strengthen you, maintain your core so you don't fall, which we know does lead to fracture. Smoking, please don't do it. Yet one more doctor telling you it's a bad idea. It's bad on your bones. Limit your alcohol consumption. Really, 1 glass of wine a night is where you should be cutting yourself off. More than that, we do see some evidence of bone loss through free radical generation with alcohol intake. Maintain a healthy weight, and that goes both ways. Try to stay in that healthy BMI. Don't lose too much. Don't gain too much. Yo-yo dieting is a very bad idea for bone. When you yo-yo diet and you lose a lot of weight very quickly, you generally lose muscle as the source of your weight, and therefore you lose bone. And then just make sure your diet is balanced. I get a lot of questions about special supplements. What about vitamin K? What about boron? What about zinc? And the reality is that an overall rainbow diet, all the basic food groups represented, is generally sufficient in the average patient to really check all of your boxes for bone health. So you don't need to overly focus on acid-base status of your diet. You just need to focus on good, healthy calories. And, a cheat day here and there never killed anybody. So what about my job? So what happens when diet and lifestyle really aren't enough to prevent bone loss or fracture? This is when the prescription pad comes out. This is when, conservative measures haven't worked. Maybe when there's been a fracture. I try to work with patients when there hasn't been a broken bone or the numbers aren't that bad. But gosh, if we start to see broken bones, then it's probably time to do something. And I will put it, in this parallel. I would be irresponsible as a bone doctor to let patients go untreated with a fracture, just as a cardiologist would be irresponsible to let patients go untreated following a heart attack, or a neurologist to let patients go untreated after a stroke. So a lot of times patients will come and they're very, very anxious about starting medications for their bones. And I'm absolutely willing to partner and do everything conservative possible. But again, taking that oath, that I'm going to do the right thing by patients. If there's been a broken bone, we really need to have a serious talk about that. So when it comes to medications, believe it or not, there's still work to be done. The exercise needs to stay on board, the calcium, the vitamin D, the healthy lifestyles, that never falls off the to-do list. But then there are things that I can do too in terms of medications. So there's two main kind of bins or categories of medications. There's those that tackle that Pac-Man cell. So remember that osteoclast that breaks down bone? Well, there's a whole host of drugs that really target that cell and prevents bone breakdown. And then there's a few medications that actually target the osteoblast, that bone building cell, to kind of put bone back, to really promote bone building. And just remember, the goal of treatment is always fracture prevention. It's wonderful when we see the numbers look better, but remember, all of these treatments that we'll even talk about today really reduce the risk of fracture first and foremost. And I too get disappointed sometimes when patients have been doing their darndest, lifestyle and diet, and we've started medications and the DEXA looks exactly the same. But listen, as long as the numbers are stable, as long as there has not been a new fracture, we just have to have faith that fracture risk has been reduced generally by about 50% with most of these medications. So the pharmacologic therapies that we use in patients, you can see them outlined here. There's many more anti-resorptive or anti-breakdown medications than bone building medications. We have a few more in that category now, thankfully, than we used to. The most common ones that you all have probably heard of are the oral bisphosphonates, so things like alendronate or risedronate or abandronate. That would be good old-fashioned Fosamax, to give you a brand name that you've probably all heard of. There's an IV formulation of bisphosphonate now called zoledronic acid or Reclast. And then there's a twice-yearly subcutaneous injection called denosumab or Prolia that we use quite frequently in patients. And then in the bone building category, we've got some injectable medications that patients either give to themselves for up to 2 years, the teriparatide and abaloparatide. And then there's a newer kit on the block as of April of 2019 called romosozumab, which is a monthly set of injections given in clinic for up to a year that again helps to build some bone back. These are kind of getting down into the weeds with the specific medications. I do still get questions about estrogen, and certainly it's not that estrogen is bad for bone. We love estrogen in the bone clinic, but we also know that since 2002, we've had to take a second look at estrogen, specifically if women just want to start it for bone health. We actually have better drugs for bone health in that list that I just showed you. But if a patient is on estrogen for menopausal hot flashes or mood instability or challenges sleeping, then by all means, we don't stop it. We just generally don't start it as first-line therapy for bones because it can carry breast and cardiac adverse events with it. There's selective estrogen receptor modulators, so something called raloxifene, similar to tamoxifen for breast cancer. It's a daily pill. It doesn't really have hip fracture protection data associated with it and can increase risk of blood clots, but it's kind of a milder drug, and many patients like it, if they're a little bit wary of some of the more potent agents that we have. There are bisphosphonates, as I mentioned. These are kind of the more common drugs. They've been around for a very long time, so since the 90s. So we have all sorts of safety data on them, inclusive of the weekly pills that you can see here, as well as the once-a-year formulation, which is called the IV zoledronic acid, and then Prolia or denosumab, which is the twice-yearly injection. And then who do we think about for some of these more advanced medications? So some that are injected or infused rather than the oral. So some patients have difficulty swallowing or have reflux issues. So pills are contraindicated in those patients. Or gosh, sometimes patients are religious about taking that once a week pill. And unfortunately, the bone density keeps going down, or there's a new fracture. So we think, gosh, we need something a little bit stronger. So we may turn to the IV bisphosphonate or denosumab after that. There are side effects to everything. There's side effects to vitamins. There's side effects to acetaminophen or ibuprofen. And guess what? There's side effects to bone medicine too. In general, we can see bone pain with some of these drugs. So if you're not getting good calcium and vitamin D, which again, it's my job to help optimize you on before you start these medicines, you shouldn't have that as a side effect. We can see some dips in blood calcium. Again, we try to tee everything up before we even start these drugs to keep you out of the weeds on that. We can see infusion reactions with that first dose of the IV medication, the zoledronic acid or reclassed, about 20% of the time. So I always say, please don't do it the day before Thanksgiving or the day before a trip that you're about to take, because I don't need a phone call saying I've ruined your day. So 20% of the time, plan for it, and hopefully you won't be in that category. And then a very rare risk of something called jaw necrosis. It's rare. It's about 1 in about 400,000. Generally seen in the context of a dental procedure that's invasive, so an extraction or an implant. So if you certainly have any of that work coming up, we tell you to hold off on therapy until you're done with your work. And if you need a procedure while you're on treatment, there's a way to kind of time it to minimize that risk. But again, at the end of the day, if I'm worried about a 1 in 400,000 risk of a jaw complication versus a real hip fracture, I don't know. We have to talk that through. And then finally, another kind of takeaway point that I really, really need to impress upon everyone listening is denosumab or Prolia. It's a very convenient medication, which is why a lot of primary care doctors like it, and rheumatology offices, et cetera. It's just a every 6-month injection. The challenge with that medication is that you have to get it every 6 months. If you skip a dose, if you are late with a dose, in fact, your bones can have this rebound effect where the osteoclasts, those Pac-Man cells, which had been on pause, all of a sudden wake up and they have a party, and your bones can break down at a very rapid level. And in fact, we can see spontaneous vertebral compression fractures in patients who miss their dose of Prolia. So it was kind of our nightmare during the pandemic. We had to beg and plead for patients to come in, despite everything being closed, so we could give them their shots. So this is not a medication to take lightly. It's a commitment. And then even coming off of it is definitely a process. It's not impossible to start Prolia, but it can be very, very challenging. So we have to kind of work through that together. So again, a good take-home point that you to know what you're signing up for. And then contraindications to therapy are here. Again, calcium and vitamin D deficiency, we try to get all of those things, teed up before we start. Women of childbearing age, we try not to start these medicines in younger women. Renal insufficiency for the bisphosphonates, the denosumab is the only thing that's allowed for renal insufficiency. Swallowing difficulties, we can't use the pills, and then low blood calcium. And then finally, thinking about the bone building medicines, the, teriparatide or abaloparatide, patients will bristle when I bring up the fact that this is a nightly injection, given up to 2 years, kind of like insulin that's given in the abdomen. And, nobody likes the idea of giving themselves a shot. But again, there's some bone building activity there. There's this monthly set of injections given in clinic, romosozumab, for up to 1 year. The challenge with those, though, is you can't just stop those either. You don't have that tremendous rebound effect like we just talked about with denosumab. But if you go on a bone building drug for 1 or 2 years and do nothing thereafter, you will lose everything that you've gained, which if you've just completed 2 years of injections, it's a shame to lose ground after that sort of dedication. So you have to follow up with either an anti-breakdown medication in the form of the pill or the infusions or the injections that we just talked about. So, how do we know whether or not to start a medication? Well, like I said, if you've had a broken bone, I don't need a lot more convincing, but sometimes it's nebulous. Sometimes the bone density is, on the fence, or, it's been stable for many years, or patient preference. We have to work through it together. There is something called a FRAX calculator, and this calculator is something you can kind of look up and do on yourself. It's for all different countries. This is for the UK, but you can look here at the variables, looking at age and sex and weight, family history of fracture. You put in the DEXA data, and ultimately it can spit out a general risk profile for your risk of fracture in the next 10 years. It'll give you the 10-year risk of a major osteoporotic fracture based on the data entered, and then a 10-year risk of a hip fracture specifically. And in general, we kind of encourage treatment for a risk greater than 20% at any site, or 3% at the hip. And again, this is, a general rule. This does not help me in a face-to-face interaction with every single patient, but sometimes it can be helpful. So it's useful if someone, doesn't really have lots of risk factors, not really sure what to make of the DEXA data. It helps patients understand why they do or don't need treatment. It's not helpful to me if someone is actively fracturing. It's not helpful to me if someone's actively losing bone. Maybe you have osteopenia, range bone density, but you've lost 8% over the last year, and we don't want to wait till it's osteoporotic before we treat. And then for the very old and the very young, it's also not terribly useful if you've been on treatment in the past. And again, it doesn't count if you're fracturing or if you have other reasons to start a bisphosphonate or other medicines. So if you've just been started on high-dose steroids and are going to be on them for the next year, we might try to prevent bone loss by, getting you on medication before waiting a whole year and then watching the numbers decline. Because I always tell patients it's much easier to prevent bones from breaking down than to try to get bone density back. And then again, there's some limitations. The FRAX only includes femoral neck bone density, but a lot of patients have osteoporosis isolated to the spine. So it really doesn't capture those patients and maybe they're full risk. And it's also not ideal for minorities and international populations. It hasn't been validated, namely because overseas there's a lack of DEXA scanning. So we don't necessarily have that data to be able to build into the calculator. So I do want to leave you with a few pearls. I haven't had a chance to monitor the Q&A, but hopefully we've left ourselves a little bit of time to do that. Number one, fractures aren't normal. So I know it used to be, and I hope we're not talking like this anymore, but I hear, well, grandma, our mom broke her hip a couple years ago, but she was 80 when she did it. Whoa, that's not normal to break your hip, to fall and break your hip. It's not normal to have a heart attack or stroke. So why would we normalize a fracture? So slipping on the ice and breaking your wrist, that's not a normal fracture. Coughing loudly and breaking a rib, that's not a normal fracture. These should all be little, red flags in our minds that maybe something is amiss in the skeleton. Men get osteoporosis. I see many, many women in my clinic, and through treating them, they'll say to me, my husband or my son or my partner or whomever, he's been on steroids the last 6 years. Do you think he should get a DEXA scan? Yes, absolutely. Again, we need to start including our men in this discussion. Their bones are just at risk as ours. We want to think about secondary causes of osteoporosis and work them up. So all those lovely labs I flashed up there, it's a lot, but it's important to kind of clear the decks before you start thinking about treatment. Calcium and vitamin D are as important as the other medicines on the list. So every single clinic visit, we go through the calcium, we go through the D, we go through the exercise. I want to make sure people are still doing what they should be doing on their end to maintain good bone health. We always want to replete vitamin D, make sure calcium is teed up before we start treatment. The FRAX calculator is helpful, but it's not the be all end all. So some patients will come in and say, well, I don't meet any of those metrics that you just showed, the 3% and the 20%. I said, well, yeah, but you just broke, your wrist, or you just lost 5% bone density in your spine this year. Let's not wait till the FRAX tells us it's time to treat if we have other reasons to do it. And then we do have a metabolic bone clinic, and the information is here. For our clinic. I'm not going to lie, we're very, very busy in our clinic. I always tell patients you're not alone, clearly, because you had to wait many months to get your appointment. But I do feel like we offer a comprehensive approach, and we've taken it upon ourselves, hopefully, to disseminate some of this information into the community, to you and healthcare providers as well, to try to spread the wealth in terms of osteoporosis treatment, because it's clearly a disease process that's not going anywhere. So with that, I think I have left some time for some questions, and I'm happy to answer any of those that may be out there.
Great. Thank you so much. So our first question is from Carol Rose. How do I know how much twisting I should do in yoga?
Oh, Carol Rose, that is a wonderful question. I get it a lot. First of all, I want to commend you on the yoga. I love yoga. I love Pilates for my patients. I think the flexibility, the core strength, the balance training that comes with exercise like that is really pivotal for preventing fractures. And if there's strengthening in there, and breath work, and frankly, mindfulness that we all need these days. So congratulations on doing that. It's low impact, so we don't worry as much about, major things, but you're right. There are some poses with yoga that are not ideal. So there's hyperextension of the spine, twisting exercises. In general, we try not to hyperextend the spine if we have known osteoporosis. So the sun salutations, I'm not a yogi, but sun salutations I know is not an ideal one. Excessive twisting where you're kind of hyperextending to one side or the other. And if you do twist or bend, the idea is that you mobilize not the bone, not the back, but that it should be really recruited from the abdominal muscles, and the lats is another muscle group, to have controlled motion, nothing too fast. Again, to stabilize the spine, to stabilize the back with the muscle groups, not the back itself. There's some very helpful information on the National Osteoporosis Foundation website regarding specifically yoga exercises that can be done for people with osteoporosis or low bone density. And I would encourage you to take a look at that. It's actually not called the National Osteoporosis Foundation anymore. They just changed the name and it escapes me right now. But if you Google National Osteoporosis Foundation, it will still pop up with that website. And there's some very nice material there again about yoga specifically.
Great. She has another question too. This is about calcium. Thinking about 600 milligrams of calcium at a time. So if you have osteoporosis, and you have your 1200 milligrams in your food, then should you not take the supplement?
Correct. So again, that total, that 1200 is the supplement plus the diet. So everything you get should not really exceed the 1200 milligrams. Now, you don't have to be overly, crazy about it. If you're 1100 one day and 1300 the next, it's not the end of the world. But if you're successful in getting 1200 milligrams a day just through diet alone, then you do not need a supplement. And patients will sometimes say, well, what's the big deal? Is it not better if I get 1500 a day or 1600 a day? Well, it's not ideal because actually extra calcium comes out through the urine and in fact could lead to kidney stones and calcification of the kidneys. So let's not get into that territory either. I think that we don't want to trade one problem for another one.
I had a question about, I love spinach, but I've been told that spinach, even though it has calcium in it, or is it vitamin D? It has lots of wonderful things, but it can also leach out calcium in your bones. Is that correct?
No, that's not.
Oh.
I don't know where that came from necessarily.
I think it came from either.
But we can talk about leafy green vegetables and calcium. So yes, leafy green vegetables are a source, and I stop myself, as saying good source, because they're a source of calcium. The challenge with leafy green vegetables is that you have to eat a lot of them in order to get a decent amount of calcium. So, we all know spinach is incredibly disappointing, right? So you get this beautiful big bag of spinach and then you cook it and it cooks down to like this. The problem is you need cooked spinach wise, you need about 8 ounces of cooked spinach, which is about this much cooked, to get even close to, say, 100 milligrams of calcium. So you kind of have to go through the food lists and see exactly what it is that you're getting. But if you're having a nice big green salad, at the end of the day, if you were to heat that salad up and cook that spinach down, it's probably not going to be that much at the end of the day. Similarly, broccoli, 8 ounces of broccoli, which is a fair amount of broccoli, is only 80 milligrams of calcium. So whereas I love a green diet, I love a plant-based diet, I love, all the colors of the rainbow, because there are so many other good things in that sort of food, vitamins, minerals, etc., antioxidants. As far as calcium goes, it's not always as satisfying when you do the math.
I love spinach, but I don't. That's a lot of spinach.
It's a lot. Similarly with kale, that's another one. And again, all these health benefits, I'm not poo-pooing any of those. I'm just saying that in terms of calcium, it can be tough and enlightening. I think if you can get these food apps now on your phone or, go online and check out the food list. But when I see patients in clinic, I have a food list I give them. There's always kind of a fallen face that I see when they get to the fruits and vegetables section.
Would a tooth implant make sense for an 82-year-old male who is on prostate cancer hormone treatment?
That is a tough one. So what this question is getting at is, something called androgen deprivation therapy, which is in women, we see it a lot with a drug called aromatase inhibitors, and men have an equivalent in prostate cancer that basically takes testosterone levels and renders them to zero, or takes them to zero, to prevent the spread of prostate cancer. And much like estrogen in women, that's very, very important for bone health. Testosterone is very important for men in bone health. And so when you take testosterone from whatever the baseline is to zero, you can see a lot of bone loss. Some men, because of just the prostate cancer and the androgen deprivation therapy, are put, thankfully, on bone protecting medications. We have a lot of work to do in that field to introduce those medicines into these protocols. And then some men, unfortunately, even have, beyond the prostate cancer, have bone disease as a result of the prostate cancer, bone metastases that require not only just kind of osteoporosis dose medications, but sometimes even higher and more frequent doses of these osteoporosis drugs because of the bone metastases. And in both of those cases, we do have to think about jaw complications when it comes to invasive dental work. Jaw complications are much more common and more regular in patients who have frequent high dose medication, who have underlying malignancy and therefore have frequent high dose medication, and who have other, medical conditions. So, even though my quote earlier was about 1 in 400,000 for the average patient for jaw necrosis in the setting of these medications, if you have cancer and you're getting higher and more frequent doses, that rate actually does increase significantly. So I am not an oral surgeon and I don't know your mouth, but I think that's the discussion that needs to take place, is how important is it that this dental work be done, weighed against the risk of, again, a jaw complication if in fact you're on medications for your bones in general, or gosh forbid there are bone metastases and on higher doses of those medicines. So it's kind of a long-winded question, but I wanted to frame it for other people listening as to why it's an important question.
Thank you. There are some good questions, or a lot of questions here. So Lourdes asks, I've been losing bone density for years. Doctors have observed but never prescribed any medication to stop density loss. I'm currently waiting for an appointment to discuss lab results because my last DEXA scan shows I have osteoporosis. Never broken a bone and there's no family history. The doctor is reviewing my lab results, suggested if indeed I have osteoporosis, to do an infusion treatment because I have reflux problems. Would an infusion be the best treatment at this point?
Lourdes, that is a great question. And I have not met you and I've not seen your lab. So all of this is with that caveat. In general, correct. If someone has osteoporosis and is losing bone, our goal is to stop that decline, and obviously to stop the risk of fracture that comes with the decline. And as I think I had said on one of the prior slides, if someone has reflux disease, we generally try not to treat with pills because it can worsen, and pills specifically bisphosphonates, so things like alendronate, also known as Fosamax, risedronate, also known as Actonel, because those pills can cause esophageal irritation, worsen reflux, etc. So kind of the next step down the line is to bypass the gut entirely, either with a once-a-year infusion, which is the IV zoledronic acid or reflux, or this twice-a-year injection, the denosumab or the Prolia. So I think that thought process sounds perfectly fine. Obviously, you always want to review the lab work and review kind of other reasons for why you might be losing bone, not just blame it on age, but is there anything else that may be going on resulting in this bone loss? And those things should be corrected as best as possible too. But the treatment thought process sounds like a good one.
Okay. Is jaw necrosis the only bad side effect from starting Reclass IV? How often do you need to get Reclass? Is it for life?
Right. That's a great question. So is it the only side effect? No. So if you open the package insert, you'll probably fall over backwards because there's everything from jaw necrosis to low calcium to your skin will turn green to, how those inserts work. The most common ones, again, that musculoskeletal pain, that flu-like illness. I can't stress that enough. For the first infusion, only 20%, kind of like what people were reporting with the COVID vaccine. Just you don't feel well for a couple of days. Does not last a whole year, I promise. But for a couple of days, it can take the wind out of your sails. Are there additional side effects? Probably the only one that I did not get to today, generally because it comes up in the questions. So thank you to give me this forum to talk about it. Is many patients will come with the concern, and because it is real, of a very, very, very rare risk and side effect of these medicines, all of the anti-breakdown medicines, called an atypical femur fracture. And what that is a hip fracture that occurs, if we look at the hip kind of like this, we've got the ball and socket joint, and then we've got the femoral neck. That's usually where a fracture happens, is either in that ball and socket or the femoral neck. An atypical hip fracture occurs down here. It's further down in the femur, and they are rare. They're about 1 in a million. But why do they happen? Well, why these atypical femur fractures happen is that in some patients with long-term use of osteoporosis medications in that anti-breakdown category, so the bisphosphonates, either pills or IV, or the denosumab, if you're on long-term use of those drugs, you can have too much of a good thing. Remember how I mentioned earlier on in the talk, your bones are always building up and breaking down. And one of the reasons for that is so that they can remodel, they can rebuild, and they can stay flexible. If you overtreat bones, if I took you and treated you until the end of time with these drugs, you can paralyze that process, that remodeling process. And when that happens, in theory, your bones can become old, they can become brittle. And with that brittle bone that can accumulate over time with too much treatment, we can maybe see these very strange 1 in a million, I do want to stress how rare they are, thigh bone fractures. So in general, with osteoporosis medications, the plan is not to treat indefinitely. For the pills, we in general, and this is a very patient-specific discussion, this whole drug holiday concept. In general, in patients, appropriate patients, we do pills for about 5 years. With the infusions, we do between 3 and 5 years. And then with the Prolia, the denosumab injections, we can do up to 10 years. There's some safety data, and then we're still collecting data beyond that. But we do always want to, every year, every couple of years, reassess and think, gosh, do we still need this medication? Is your bone density stable? Are you fracturing? How's your health? And you always want to reevaluate the need for the medication, because if appropriate, we do try to pause the medication at certain junctures, 3 years, 5 years, 10 years, to allow the bones to wake up again, to make sure, not to make sure, but to help prevent potentially that very strange thigh bone fracture. And then if you start to lose bone again, if there's a new health condition which might threaten your bone, gosh forbid there's a new fracture, it's like hitting the reset button on that clock again, and then you can restart treatment. Sometimes patients will come and they'll say, gosh, I already did 5 years of Fosamax. I'm done. I can't have it anymore. And I said, well, no, it's been 10 years since you had it. It's time to reset the clock, and you could reevaluate and restart treatment. So that's the other kind of big picture side effect we talk about with the infusions, with the pills, and even with the injections.
Thank you. Harriet has a question about Prolia. What adverse effects have you seen with Prolia? I have osteoporosis, but I stayed away because of the negative side effects. Also, what percentage of patients have had these side effects?
Yeah, so Prolia, I will say just somewhat flippantly, Prolia is actually extremely well tolerated in patients. And I think that's why we're seeing so much more of it in the community, is because it's easy to give, like a flu shot, and it is well tolerated. And some patients do experience a dip in blood calcium levels. That's generally patients with underlying kind of kidney disease. And when your calcium goes low, you can get kind of numb and tingly. It's not a fun experience. There are some reports of kind of immune related side effects. So in people who are immunocompromised, so if you're on high dose steroids, if you have lymphoma, HIV, AIDS, there's a slight increased risk of what we call atypical infections in those patients, to the tune of about 1 to 2%. It's very, very rare. And those infections are things like urinary tract infections, upper respiratory infections, and skin infections. So if you're a healthy individual, and generally don't worry about that risk too terribly much. I think the biggest thing, Harriet, to keep in mind is that what I talked about before, which is that rebound effect of the drug when you come off of it. It's real. I've seen sadly many a patient who will come to our clinic with multiple spine fractures after, skipping a dose, or being told, maybe by an oral surgeon, hey, skip your denosumab this month. We need to do an implant, and, it'll be fine. It's actually not fine. It's dangerous. I've sent many an oral surgeon kind of nasty grams and and scientific papers about this phenomenon just to get the word out. But that's probably the biggest one that I worry about, and the one that, is the requires the most counseling. I will say in my practice, if I have a patient who is reluctant to start medication or really does not want to be on medication for a long time, is extremely interested in doing a drug holiday like we just talked about, I generally don't start the injections. I'll start the infusions and the pills because we can stop those at any time. That's a personal preference for me, but I think it helps kind of marry the interests of the patient, which is, I'll do this, I'll partner with you, but I don't want to do it forever. And, obviously treating the bones, which is my priority too.
Okay, thank you. So we have 4 more minutes left. We still have some good questions. So are you okay with staying a few minutes after?
Yep, I think I can do that. Yeah.
All righty. Okay. I've been told that one needs magnesium with their calcium supplement. Is that true?
Yeah, I get that question a lot. So sometimes magnesium comes already with the supplement, and I'm fine with that. But the average diet has ample magnesium, where I would not necessarily go out and buy a separate magnesium supplement. It can cause a lot of GI distress, and is not as well tolerated as people might otherwise like. So I don't typically recommend extra magnesium. It's in a healthy diet.
Okay. If you have been diagnosed with osteoporosis, should you continue to take prescribed medication? I take raloxifene.
Raloxifene, yeah.
Raloxifene.
Should you continue to take prescribed? So raloxifene is that selective estrogen receptor modulator. It's kind of akin to tamoxifen, which is the breast cancer drug. That one you can take long term. There's no kind of atypical femur fracture like we talked about. There's no jaw necrosis. The downside to raloxifene is if you're at risk for hip fracture or if your hip bone density is low, it really doesn't give you protection in that location. It's good for spine, not as good for the hip. And also it does carry with it a risk of blood clots. So if you're someone at risk for blood clots or have had a blood clot in the past, it's certainly not anything we're excited about prescribing. But that one you can take for longer term without any issues.
Great. Can one reverse bone loss short of taking medication?
That's a tough one. So it depends on the cause of bone loss. So in some extreme cases, there's nutritional deficiencies where there's severe calcium deficiency or vitamin D deficiency, where if you replace that calcium and that vitamin D, the bone, in fact, can remineralize. And I've seen this in patients, for example, with celiac disease, where they come and they've been malabsorbing nutrients for a very long time, and you give it back to them, and it's like you fill up their coffers, their stores again. Patients oftentimes will ask about exercise. Well, if I start exercising more, will I be able to get the bone back? Sometimes. So in general, just upping the exercise will help you maintain your bone. It's hard to gain bone. If you are a true couch potato and you've never exercised, a day in your life, and you start exercising, yes, there can be an opportunity for some bone formation there. The challenge is that when you think about bones, you have to think about it kind of like a scaffold. And when you lose bone, one of two things can happen. You can either thin the bones themselves. So this is the trabeculae. The trabeculae can thin, and when they thin, you can thicken them back up again. But sometimes when you lose bone, it's because they break apart. And once the trabeculae are fractured like this, not much can put them back together again, a la Humpty Dumpty, without the use of medications, particularly the bone building medications, which can put them back together again.
Okay. That's a good analogy with the bones. The infusion treatment is once a year. So how many years do I have to continue the treatment?
Yeah. So again, 3 to 5 is a general rule, but that's assuming a lot of things. That's assuming that the treatments are successful. Your bone density is stable, you're fracture free, your health is otherwise good. It's assuming that at the end of those 3 years, you're not all of a sudden started on high-dose steroids or an aromatase inhibitor or androgen deprivation therapy. It depends on your bone density at baseline. I have some patients, they have very low bone density and they fall twice a week. So I'm not in any rush to get patients off of medication when that's the situation we're dealing with, because at the end of the day, what are we worried about with long-term use? I'm going to go back to those 2 big side effects, the jaw stuff and the femur fracture stuff. That's our concern, right? 1 in 400,000 1 in a million with long-term use. If you have very low bone density, you're falling, you're on high dose steroids, you're in and out of the hospital, etc., I am far more worried about a run-of-the-mill osteoporotic fracture of the spine, the wrist, the hip, than I am about this or this. So I'm not in any rush to stop therapy if it's not time.
There's two, this is the same, but two people have asked. Your office location and phone number for consultation. Are you at any other places besides Bayview, which is up in Baltimore? We're in, Montgomery County here.
Sadly, no. So the Bone Center is located at Johns Hopkins Bayview. We do have one provider who's at Green Spring, which is even further north than you all. We used to have a Bone Center at Sibley. Unfortunately, that is no longer in practice. That's been for a couple years now. We haven't been at Sibley. So no, unfortunately not. It does require a schlep up to Baltimore, which it is. I get it. My parents are in the DC area and I drag them up to Baltimore all the time when they've got health issues. But, we do offer even just one-time consultations in our clinics. If you're happy with your current provider and you just kind of want to run stuff by us, we're always happy to do that. So it's not necessarily a lifetime commitment to the trip to Baltimore, but if you just want someone to take a look at your profile, we do that, if necessary.
Okay. And then last but not least, may we have a copy of your presentation? In the sense of the PowerPoint presentation.
Yeah, I think we can do that. That's fine. I've shared that with other groups before.
Okay. So just thank you so much, Dr. Moseley, for your time today. This was extremely informative for our participants as well as me. And I always learn something new. And so I really do appreciate your time. For those who are interested in knowing, the recording will be available in the coming days, and we'll make it available on Suburban's YouTube page. Yeah. Thank you again, Dr. Moseley. Thank you everyone for coming today, and have a happy Thanksgiving to you and your family. Bye, everyone.
Take care, everyone. Thank you for having me.